Welcome back to the deep dive. Today, we were taking on a region that, well, it really embodies the difference between just knowing anatomy and achieving true surgical mastery. We're talking about the posterior abdominal wall and the extraordinarily high stakes anatomy of the retroperitoneum.
That's right. It's a space that demands respect.
Absolutely. So, if you want to understand how the elite professionals navigate this complex, vessel-rich space safely, this deep dive is really your blueprint. Our sources today are drawn from some of the most advanced surgical texts out there. And our mission for you, the listener, is achieving not just knowledge, but a deep functional understanding of this anatomy.
Exactly.
We're aiming to go beyond just naming structures. We want you to master the critical avascular planes, understand the embryological logic that actually created them, and detail the complex, often life-saving surgical maneuvers used to access the great vessels and the vital organs contained within.
That's the perfect way to frame it, because when you're operating in the retroperitoneum, you're really at a central surgical crossroads.
A nexus, almost.
A nexus, exactly. This space is ground zero for procedures involving the great vessels. We're talking the aorta and the inferior vena cava, or IVC, as well as major structures like the colon, the pancreas, the kidneys, and the adrenal, or suprarenal glands. Surgical success here, it doesn't rely on luck. Not at all. It relies entirely on understanding the embryological origins and the resulting fascial compartmentalization.
Why that embryology connection?
Because that compartmentalization, born from development, provides the only safe, predictable roads for dissection, both sharp and blunt. It creates the surgical highways, so to speak.
Okay, so let's lay out the plan for today. We'll first establish the sheer variety of procedures this anatomy governs. It's quite a list.
It really is.
Then we'll spend significant time on the embryology, why these planes exist in the first place. We'll explore the precise anatomical compartments and their unique boundaries.
And those boundaries are key for understanding spread of disease.
Definitely. Then we'll dive deep into the critical trauma classification system for hemorrhage in this area. And finally, we'll detail those essential mobilization maneuvers, the Kocher, the Cattell Braasch, and the Mattox, to understand how surgeons physically, move the body's interior to gain access.
Sounds like a comprehensive plan.
Yeah.
Let's get started. Hashtag tag check on I. Core surgical procedures of the retroperitoneum.
All right. To truly appreciate the complexity and, frankly, the critical nature of this anatomy, we need to internalize the staggering range of operations that depend on it. This area really is the main operating theater for high-level general, vascular, and urological surgery.
Yeah, the list of procedures really highlights the functional importance of this space. It's a central conduit and a repository for so many vital organs. Let's start maybe in the upper retroperitoneum involving the pancreas.
Okay.
We're talking about the pancreaticoduodenectomy, which everyone knows as the Whipple procedure. This requires massive mobilization and really detailed retroperitoneal dissection, especially around the superior mesenteric artery and vein.
A huge undertaking.
Huge. Then you have distal pancreatectomy, sometimes paired with a splenectomy, removing the spleen as well, and even total pancreatectomy in some cases.
And you mentioned the spleen. That often dictates the terms of a left-sided retroperitoneal dissection, doesn't it?
It absolutely does. Splenectomy, removing the whole spleen, or partial splenectomy, they're often performed alongside procedures on the left kidney or the distal pancreas. And doing that requires really careful mobilization of the spleen's retroperitoneal attachments. You have to free it up safely.
Okay, moving down, let's talk digestive tract. The colon and rectum. They seem heavily dependent on this anatomy for mobilization.
Immensely dependent. When you're performing a right or left hemicolectomy, removing half the colon, or a total abdominal colectomy, total proctocolectomy, anterior resection for rectal cancer, or an abdominoperineal resection. Well, in all of those, the surgeon absolutely must mobilize the ascending or descending colon.
And these parts of the colon are what we call secondarily retroperitoneal, right?
Exactly. They weren't always fixed there. And they're safe release from the posterior wall using those landmarks called the white lines of Tolt. That's the entire foundation of these operations. You literally cannot perform the surgery safely without peeling the colon off the back wall using these specific planes.
Got it. And the stakes just keep going up when we talk about vascular interventions.
Oh, absolutely. These are the operations that require deep, often challenging retroperitoneal access right down to the great vessels themselves.
So we mean things like abdominal aortic aneurysm repair.
Yes, repairing aneurysms in the aorta. The truly demanding thoracoabdominal aortic aneurysm repair, which involves both chest and abdomen. Aortobifemoral bypass for severe peripheral vascular disease. And also the specialized surgical management for mesenteric ischemia, lack of blood flow to the intestines, which includes procedures like antegrade or retrograde bypass, or even embolectomy, removing a clot.
Let's take that aortobifemoral bypass example. Why is that retroperitoneal access so critical there? What's the specific danger?
It's absolutely crucial because the approach to the infrarenal aorta, the part below the kidney arteries, must be through a careful, controlled retroperitoneal dissection, usually through the inframuscolic region below the colon's mesentery.
Why not just go straight through the abdomen?
Well, the goal is twofold. First, avoid manipulating the bowel unnecessarily, which reduces the risk of ileus or the bowel slowing down after surgery. But critically, you have to keep the prosthetic graft, the artificial artery used in the bypass, from ever coming into direct contact with small bowel.
Ah, infection risk.
Catastrophic infection risk.
Yeah.
If that graft gets contaminated by bowel contents, the patient faces life-threatening complications like graft sepsis or an aortoenteric fistula. So, safe retroperitoneal control and isolation of the great vessels is mandatory for the long-term survival of that graft.
Makes sense. Okay, what else?
Well, finally, we have procedures for the primary retroperitoneal organs, those that live there from the start.
Like the kidney.
Exactly. Requiring nephrectomy, removing the whole kidney, or partial nephrectomy, removing just part of it, and the adrenal or suprarenal glands sitting atop the kidneys, requiring adrenalectomy.
And miscellaneous procedures.
Right, things like kidney transplantation, which demand safe, precise access to the iliac vessels down in the pelvis for the anastomosis, the connection, and also repair of posterior abdominal wall hernias. And, of course, the ultimate test of this anatomical knowledge, trauma,
Right.
where a trauma laparotomy, opening the abdomen emergently, necessitates mandatory exploration of the retroperitoneum if there's any suspicion of vessel injury, particularly a central or expanding hematoma. #TAG2, the embryological foundation of surgical planes.
Okay, now we shift gears. We're going to the absolute bedrock of surgical safety in this region because before you even think about making an incision, you really have to understand why the tissue plane you're aiming for is even there.
And that comes down to development. It all comes down to the embryology of the primitive gut. That developmental process is the immutable blueprint for the safe, avascular plane surgeons rely on every single day.
Okay, let's start at the very beginning then. The sources detail that the primitive gut tube, which eventually becomes the foregut, midgut, and hindgut, its inner epithelial lining, is derived from the endoderm. That's the layer lining the embryonic yolk sac.
Correct. And critically, all the supporting structures, the muscle layers, the connective tissue, the supporting membranes or mesenteries, these develop from the surrounding spongenic mesoderm.
And initially, this gut tube is just sort of hanging there.
Pretty much. It's initially suspended freely within the intraembryonic column. That's the cavity that will become the peritoneal cavity, held in place by its mesentery, like a sheet.
And this cavity has its own lining, right?
Yes, the coulommic cavity is lined by the parietal layer of lateral mesoderm. Think of it as the wall lining. And the gut tube itself is covered by the visceral layer of that same lateral mesoderm, the organ lining.
So suspended between these layers.
Right. But here's the key point. Here is the moment of creation for our surgical planes. As the embryo grows incredibly rapidly, the primitive gut doesn't just get bigger, it rotates complexly and differentiates.
Like the rotation of the midgut.
Exactly.
Yeah.
And during this dynamic process, specific portions of that original mesentery, which initially allowed the gut to be free, they permanently adhere, or fuse, to the posterior parietal peritoneum, the lining of the back wall of the abdominal cavity.
So structures that were once free, suspended by a mesentery, they lose that freedom and get kind of stuck to the back wall.
Precisely. This adherence process causes parts of the intestine or organs that developed within the mesentery, like the pancreas, to become fixed to the posterior abdominal wall without an apparent free mesentery anymore. They are now classified as secondarily retroperitoneal. They weren't born there, but they ended up there.
And the crucial examples for surgeons to remember are...
The absolute key examples are the pancreas, most of it anyway, the duodenum, the first part of the small intestine, the ascending colon on the right, and the descending colon on the left.
Okay, wait a second. If they adhered, if they fused, wouldn't that make dissection harder? Why is this fixation actually an embryological gift, as some surgeons call it?
It seems counterintuitive, doesn't it?
Yeah.
But it's the genius of how they fuse. The line of fusion isn't just a scar, it creates a specific plane. These secondarily retroperitoneal structures, like the colon, are separated from the primary retroperitoneal structures, the ones that were always there, like the kidneys and ureters, by a distinct layer of loose tissue,
And that layer,
the avascular plane of areolar tissue that forms along these lines of fusion.
avascular meaning no significant blood vessels.
Exactly. Think about it this way. When that mesentery fused to the posterior parietal peritoneum, the blood vessels and lymphatics that supplied the organ within the mesentery, like the colon, were already established. They stayed with the organ. The plane between the now fixed organ and the original posterior abdominal wall simply consists of this loose connective tissue. It never needed its own significant blood supply because it was just the zone where two layers of peritoneum and mesentery met and basically tacked down.
So the surgical significance is huge. This avascular plane, the surgical highway, allows for safe, rapid, and excellent mobilization.
Precisely. By dissecting within this loose, almost wipeable areolar tissue, a surgeon can peel, say, the ascending colon medially towards the midline.
Without worrying about tearing major blood vessels supplying the colon itself.
Correct, because those vessels travel with the colon.
And also without damaging the really important structures lying immediately behind that plane, like the ureter carrying urine from the kidney, or the kidney itself, or the gonadal vessels going down to the testes or ovary.
You've got it. That plane is the key to safe colorectal and pancreatic surgery. Hashtag head 3. Surgical access and incisions.
All right, we've established the why, the incredible structural safety net provided by embryology. Now, let's look at how the actual routes surgeons take to get into the retroperitoneum. The sources contrast two main philosophies, going through the main abdominal cavity versus trying to stay outside it.
That's a good way to put it. Most major retroperitoneal pathology is probably approached via transabdominal access. Typically, this means a midline incision.
Straight down the middle.
Straight down the middle. It offers the highest versatility. It allows the surgeon to survey the entire peritoneal cavity, deal with unexpected findings, and gives broad access. The incision can run anywhere from the xiphoid process, the bottom of the sternum, down to the pubic symphysis, depending on how much exposure is needed.
But using that midline incision for deep retroperitoneal surgery isn't simple, is it? It requires significant effort after the initial cut.
That's right. You have to retract all the intraperitoneal structures, primarily the massive bulk of the small intestine, which needs to be packed away, usually up into the patient's side. And then you must initiate one of those visceral rotation maneuvers we mentioned earlier, like the Kocher, to actually peel the overlying structures back and gain deep access to the retroperitoneum itself.
And that effort, that manipulation comes with a clear cost, right? The
Yeah.
trade-off.
Absolutely. It's the trade-off inherent in transabdominal access. While it's incredibly versatile, it definitely increases the associated morbidity, the potential downsides for the patient, such as a greater risk of incisional hernia developing later where the midline was closed, a higher likelihood of postoperative ileus, that's the bowel being slow to wake up simply due to all the handling and packing, and a greater risk of late small bowel obstruction caused by adhesions, those internal scars that can form after any abdominal surgery.
Which is precisely why extraperitoneal access routes are often preferred when possible. When the pathology is localized and the goal is to minimize that morbidity by, ideally, never even entering the main peritoneal cavity.
Exactly. If you can get directly to the target without disturbing the bowel, you often reduce those risks.
So what are some key extraperitoneal approaches? Let's talk about the Gibson incision.
The Gibson. This is a classic. It's an oblique incision starting low in the abdomen, maybe 2 fingers breadth above the pubic symphysis, and it's carried laterally and superiorly, kind of angling up towards the iliac crest, the hip bone.
We often hear this associated with kidney transplantation. What makes it so ideal for that specific procedure?
It provides perfect direct access to the external iliac vessels, the external iliac artery and vein down in the pelvis. These are the vessels you need to connect the donated kidney's artery and vein to.
For the anastomosis.
Precisely. The Gibson incision also allows the transplanted kidney itself to lie entirely within the retroperitoneal space, nestled in the iliac fossa, which minimizes the risk of potential complications like infection spreading into the main peritoneal cavity. So it's highly favored in urology, especially transplant, and also some gynecological procedures.
Okay. Another key extraperitoneal route is the flank incision.
Yes, the flank incision is really the quintessential approach for the kidneys and the adrenal glands when you want direct access.
How is the patient positioned for this?
Typically, the patient is in the lateral decubitus position lying on their side. Sometimes the operating table is flexed dramatically, like breaking in the middle, to really widen the space between the lower rib cage and the top of the pelvis.
Opens up the flank.
Exactly. The incision can go through the 11th intercostal space, between the ribs, or sometimes more posteriorly through the 12th intercostal space, or even below the 12th rib. The key is that it accesses the retroperitoneum directly by going through the muscular layers of the flank, the external oblique, internal oblique, and transversus abdominis muscles without entering the peritoneal cavity proper.
And for really massive exposure, especially the upper right side, surgeons might use the anterior subcostal or chevron incision.
Right, the chevron incision, which is basically two subcostal incisions joined in the midline, or sometimes modified like the Mattox incision, which extends one limb upwards. These are essential when you're dealing with really extensive pathology that involves the liver and the right-sided retroperitoneal organs simultaneously.
Like what kind of situations?
Think of a large right adrenal tumor, or perhaps a tumor involving the kidney and extending towards the liver, or IVC. It provides the best exposure for the right adrenal gland, the entire inferior vena cava, IVC, in that region, the duodenum, and the head of the pancreas, all in one view.
But even that pales in comparison, exposure-wise, to the thoracoabdominal approach.
That's fair to say. The thoracoabdominal approach is really the go big or go home option for exposure. It involves deliberately entering both the abdominal cavity and the chest cavity.
How is that done?
Typically, the incision accesses the pleural space, the chest cavity, usually via the 8th or 9th intercostal spaces. Then it continues down across the costal margin, often dividing the cartilage, cuts through the diaphragm, and then extends obliquely down through the rectus abdominis muscle, sometimes merging into the midline. It's a massive incision.
When would a surgeon possibly opt for such a large incision with all the associated recovery issues?
It's reserved for situations where the pathology physically straddles both cavities, and the surgeon absolutely must ensure negative margins, meaning getting all the cancer out, especially in big cancer operations like an esophagogastrectomy, removing the esophagus and stomach where a tumor might extend up through the diaphragm, or, as mentioned, for major vascular surgery to repair the most extensive thoracoabdominal aortic aneurysms that involve the aorta in both the chest and the abdomen. It provides absolute control and visibility, but yes, at the expense of significant patient recovery time and potential complications. Okay, here's where that embryology we talked about translates directly into clinical prediction and surgical strategy. The retroperitoneum isn't just one big space, it's functionally divided into 3 distinct compartments by critical sheets of fascia.
And understanding these compartments allows us to predict how things like infection, blood, or even tumors might spread.
Exactly, and it tells us where to find things. Let's define them based on their location and, importantly, their contents.
Go for it.
First, remember those structures that became secondarily retroperitoneal. They mostly live in the anterior perirenal space, often abbreviated as APS.
So the contents are
The ascending and descending colon, the duodenum, the pancreas, and also the root of the small bowel mesentery where it attaches posteriorly.
and its boundaries, what defines this space?
It's bounded anteriorly by the posterior parietal peritoneum, the lining you see when you first open the abdomen. And crucially, its posterior boundary is the anterior renal fascia. This is famously known as Gerota's fascia.
Gerota's fascia. Okay. So that separates the APS from the next space.
Precisely. Moving deeper centrally, we find the perirenal space, or PRS.
And this contains the primary retroperitoneal organs.
Yes, this is home to the kidneys, the adrenal glands sitting on top of them, and the upper parts of the ureters as they leave the kidneys. Now, a really crucial point the sources emphasize. The perinephric spaces, the right and left PRS, are generally considered closed medially towards the midline.
Wait, why is that medial closure so critical? What does that mean practically?
It's incredibly important clinically. It means that collections originating within the kidney space, say blood from trauma or pus from a perinephric abscess, tend not to immediately cross the midline to involve the great vessels or the opposite kidney.
So the infection or blood stays on one side initially?
Initially, yes. But because it's closed medially, that pressure forces the fluid or pus to track somewhere else, usually superiorly towards the diaphragm, or, more commonly, inferiorly down towards the pelvis, following the path of least resistance along the ureter or psoas muscle.
I see. Okay, so APS, then PRS. What's the third compartment?
The third one is the posterior perirenal space, or PPS.
And what's in there?
Actually, not much in terms of major organs. It's primarily a potential space containing mostly fat. Its boundaries are defined anteriorly by the posterior renal fascia, sometimes called Zucker-Campbell's fascia, and posteriorly by the major muscles forming the posterior abdominal wall.
Which muscles are those?
The quadratus lumborum, the transversus abdominis muscle laterally, and the strong thoracolumbar fascia, which invests these muscles.
So three compartments: anterior, perirenal, perirenal, posterior perirenal, separated by fascia. The surgical planes then are literally these fascial sheets or the spaces between them.
Essentially, yes. And the most critical plane for surgical mobilization, the one we keep coming back to, is the retromesenteric plane, or RMP.
Remind us where that is again.
That's the avascular highway we discussed earlier, located between the anterior perirenal space, containing the colon, duodenum, pancreas, and the perirenal space, containing the kidney. When a surgeon mobilizes the right or left colon, they are dissecting within the RMP.
Got it. Is there another key plane?
The other main one is the retrorenal plane, which lies between the perirenal space, kidney, and the posterior perirenal space, back muscles. But it's important to realize these planes aren't totally isolated, watertight compartments, especially under pressure. They do communicate. The sources mention that the RMP, the retrorenal posterior interfascial space, and another plane called the lateroconal fascia, which is lateral, all tend to merge and communicate at a point called the fascial trifurcation, laterally.
You mentioned fluid tracking downwards earlier. Given that all these spaces eventually kind of fuse together down in the pelvis, what does that imply for diagnosis, if fluid can track so far?
It means you have to think broadly. A fluid collection, whether it's an abscess from pancreatitis originating way up in the APS, or blood from a traumatized kidney in the PRS, will absolutely track along the path of least resistance. Since the fascial planes are continuous and tend to fuse lower down, fluid often tracks inferiorly and can accumulate deep in the pelvis.
So the symptoms might appear far from the source.
Exactly. A patient might present with pain, a palpable mass, or even nerve irritation, like psoas muscle spasm causing hip flexion originating from the pelvis, but the actual source could be much higher up in the retroperitoneum. It emphasizes the interconnectedness.
Let's circle back to the landmark for actually getting into this crucial retromesenteric plane. The white lines have told it. You said they are peritoneal reflections?
Yes, they are simply the lateral peritoneal reflections, located immediately adjacent to the ascending colon on the right and the descending colon on the left. They mark where the bowel originally fused to the posterior abdominal wall.
So if it's just a reflection, what does it actually feel like when a surgeon incises it? And how does cutting this thin line suddenly open up this major avascular plane?
That's a great practical question. When you incise the white line of Tolt, you are cutting through that final thin layer of peritoneum that represents the fusion point. It's usually quite distinct, a whiter line against the pinker colon.
And once you're through,
Once you are through that fine peritoneal layer, you immediately enter the potential space of the RMP. Now, if you have applied the correct medial traction on the colon, pulling it toward the midline.
the tension you mentioned earlier. Oh,
Yes, that critical tension. Then the loose, fatty areolar tissue of the RMP should separate easily, often with just gentle, blunt dissection, like pushing with a sponge stick or carefully spreading with forceps. The distinction is key. You cut the white line, but you bluntly dissect or sweep within the RMP once you're inside. That's how you stay safe and bloodless.
this compartmentalization also gives us huge clinical clues for diagnosis, right? Like an infection starting in the kidney.
Absolutely. Early on, an infection like pyelonephritis starting in the kidney, PRS, tends to be confined within Gerota's fascia, within the perirenal space. This helps localize the problem and aids diagnosis.
But that containment can break down.
Oh, definitely. When inflammation is massive and aggressive, the classic example is severe acute pancreatitis, where powerful digestive enzymes are released from the pancreas and the APS. The process rapidly overwhelms the fascial boundaries. It can spread like wildfire through the planes, often involving both the APS and the PRS, and even bridging lymphatics can carry it further.
And finally, those famous hemorrhage signs. When blood from deep within tracks through these fascial compartments all the way to the subcutaneous tissue near the surface, we see specific signs.
Yes, the gray Turner sign, that's bruising or ecchymosis appearing in the flanks, the sides of the abdomen, and the Cullen sign, which is bruising around the umbilicus, the belly button. Both of these are dramatic, telltale signs indicating significant, deep retroperitoneal hemorrhage has occurred and tracked forward.
Okay, let's shift focus to the high-pressure, chaotic, life-or-death scenario of trauma. Understanding exactly where a retroperitoneal hematoma, a collection of blood, is located, dictates the immediate course of action. There's a critical three-zone classification system for major hemorrhage back there.
Yes, this system is fundamental in trauma surgery. It helps decide when mandatory surgical exploration is required versus when perhaps observation or other interventions might be appropriate. It's largely based on the potential source of bleeding and the risk of high-flow, difficult-to-control hemorrhage.
So let's break it down. Zone 1.
Zone 1 injuries are the midline injuries, right down the central axis of the body, overlying the aorta and IVC. These are immediately categorized as the most dangerous
Right.
because they almost certainly involve one of the great vessels, the aorta, the IVC, or their main high-pressure, non-compressible branches.
And the rule for Zone 1.
Exploration is mandatory, period. Regardless of the patient's immediate hemodynamic stability. If you see a central midline retroperitoneal hematoma during a trauma laparotomy, you must open it and find the source.
How do we subclassify Zone 1 hematomas? Because the aorta runs quite a distance.
We categorize them based on their relationship to the transverse colon's mesentery. We call them supramesocholic or inframesocholic.
That's supramesocholic, above the colon.
Right. If the hematoma is supramesocholic, meaning above the transverse colon's attachment, you have to suspect a catastrophic injury high up. This could be the suprarenal aorta, above the kidney arteries, the coeliac axis, supplying stomach, liver, spleen, the proximal superior mesenteric artery, supplying the small bowel and right colon, or the proximal renal arteries. Getting proximal aorta control, usually way up near the diaphragm, is absolutely paramount here.
And if the hematoma is inframesocholic, below the colon's attachment.
That suggests injury lower down, specifically to the infrarenal aorta or the inferior vena cava below the level of the renal veins. Again, these are massive, often rapidly expanding vascular injuries demanding immediate open surgical control.
All right, that's Zone 1 midline, major vessels, always explore. Now let's move laterally to Zone 2 injuries.
Zone 2 injuries are located laterally on either side of Zone 1. They typically correspond to the location of the kidneys and are often contained within the perirenal space, the PRS. They tend to be caused by an injury to the renal artery, the renal vein, or, quite commonly, the kidney parenchyma itself, the substance of the kidney.
Now this is where the management strategy can differ significantly from Zone 1, isn't it? Why might a surgeon not immediately explore a Zone 2 hematoma, while Zone 1 is absolutely non-negotiable?
The key difference lies in the likely pressure system involved and the anatomy of the space. Zone 1 involves systemic arterial pressure directly from the aorta or high-flow IVC return. Zone 2, especially if it's from blunt trauma causing a kidney parenchymal injury, like a laceration, is often lower pressure bleeding.
And it's contained.
Often, yes. It's frequently contained by the strong Gerota's fascia, the anterior renal fascia we talked about, and tamponated or held under pressure by the patient's own surrounding tissues and blood pressure. So, if a trauma patient with the Zone 2 hematoma is hemodynamically stable, their blood pressure and heart rate are okay, that hematoma is often managed non-operatively, at least initially.
Why the hands-off approach if stable?
Because opening that contained hematoma unnecessarily risks converting a controlled bleed into uncontrolled hemorrhage. You might disrupt the tamponade, and often the kidney can actually be salvaged if left alone to heal. Angiography with embolization might be used instead.
But not always non-operative.
Absolutely not always. A Zone 2 hematoma that is clearly expanding rapidly or is pulsatile or associated with penetrating trauma still mandates exploration due to high suspicion of a major renal artery or vein injury, which does require surgical repair. Stability is the key differentiator.
Makes sense. Finally, we have Zone 3 injuries.
Zone 3 injuries are those hematomas contained entirely within the bony pelvis.
So, suggesting injury too.
Highly suggestive of injuries to the iliac vessels, the common external or internal iliac arteries and veins, as they branch off the aorta and IVC. Or very commonly, Zone 3 hematomas result from major pelvic fractures, which cause tearing of the extensive network of low-pressure veins lining the pelvis, the pelvic venous plexus.
And management here, is it always surgery?
Management is complex. If an iliac artery injury is suspected, especially with penetrating trauma or ongoing shock, surgical exploration and repair is needed. However, much of the bleeding from pelvic fractures is venous or from the fractured bone ends themselves. In these cases, management often involves external pelvic stabilization, like a binder, aggressive pelvic packing during surgery to tamponate the bleeding, or interventional radiology for angiography and embolization to selectively block bleeding vessels. Identifying the likely source major artery versus venous plexus bone is key to directing therapy. #TagShocks, advanced surgical maneuvers for deep access.
Okay, let's get into the really advanced techniques, these visceral rotations. They feel like the true reflection of anatomical mastery in action. They aren't just random movements, they are highly controlled, specific dissections that deliberately exploit those embryological avascular planes we defined earlier.
That's exactly right. They are designed to rapidly and safely gain access to the central, deep retroperitoneum where the major vessels and organs lie.
Let's begin with perhaps the most famous workhorse of upper abdominal surgery, the right medial visceral rotation.
Right. And this usually starts with the Kocher maneuver. This is the fundamental first step needed to mobilize the C-loop of the duodenum and the head of the pancreas off the underlying structures.
How is it done? Where does the surgeon cut?
The surgeon incises the posterior peritoneum, just lateral to the second and third parts of the duodenum. Then they carefully dissect in that avascular retromesenteric plane, RMP we keep mentioning, gently lifting the duodenum and the attached pancreatic head forward and towards the patient's left.
When performing the Kocher maneuver, what are the key visual landmarks that tell the surgeon the dissection is sufficient, that they've gone far enough?
Good question. The completion of a full Kocher maneuver means the entire duodenal C-loop and the pancreatic head can be lifted cleanly away from the underlying inferior vena cava. You should be able to clearly see the surface of the IVC posteriorly.
Any other key structures to identify?
Yes, superiorly. You should be able to visualize the common bile duct as it enters the substance of the pancreas. And inferiorly, you look for the superior mesenteric vein, SMV, where it joins the splenic vein to form the portal vein right behind the neck of the pancreas. Seeing these structures allows the surgeon to assess the entire retroperitoneal margin of the pancreas head, which is crucial for cancer surgery or assessing trauma. Often the hepatic flexure of the colon, the right upper bend, also needs some mobilization to facilitate this.
Okay, so the Kocher mobilizes the duodenum and pancreas head, but you mentioned it doesn't provide full access to the lower retroperitoneum if the surgeon needs to see further down towards the pelvis.
Right. If you need even broader exposure, especially of the infrarenal aorta and IDC, you extend the Kocher maneuver into the Cattell-Braasch maneuver. Think of it as Kocher plus.
Why does the Cattell-Braasch provide such dramatically better exposure than the Kocher alone? What's the extra step?
Because the Kocher really only mobilizes the duodenum and pancreas complex. The Cattell-Braasch takes the incision started for the Kocher and extends it way down. You continue incising the white line of Tolt along the ascending colon, all the way around the caecum and appendix at the bottom, and then you carry the dissection line obliquely back upwards along the root of the small bowel mesentery, heading towards the ligament of Treitz, where the duodenum meets the jejunum.
Wow, so you're lifting up the entire right side of the colon and the entire small bowel.
Exactly. By mobilizing the entire right colon and its attached small bowel mesentery completely off the posterior abdominal wall, you essentially unspool the entire midgut embryological unit and reflect it upwards and to the patient's left, often packing it out of the abdomen entirely under moist towels.
And the resulting exposure must be incredible.
It's panoramic. It provides rapid, total exposure to the entire infrahepatic IVC below the liver, the crucial aortic bifurcation, and the iliac vessels branching into the legs, and both the right and left renal hyla, where vessels enter the kidneys. Kocher alone often obscures the left renal vein in the lower aorta IVC. Cattell-Braasch gives you comprehensive access to pretty much the entire central and lower retroperitoneum. It's a massive exposure maneuver.
Okay, that's the right side. Now let's look at the flip side, the left medial visceral rotation.
Similar principles apply. This also begins by incising the white line of Tolt, but this time on the left side, along the descending colon, moving up towards the splenic flexure, the upper left bend of the colon.
And the extent depends on the goal.
Precisely. For routine procedures like a standard left hemicolectomy, the goal is often just to mobilize the left colon medially, maybe up to the level of the inferior mesenteric artery pedicle, dissecting cleanly in the RMP. In this scenario, the spleen usually remains undisturbed in its position.
But the left rotation is most famously associated with the trauma setting, isn't it? Specifically, the Mattox maneuver.
Yes, the Mattox is the ultimate trauma maneuver for accessing the upper abdominal aorta and its branches. It's specifically designed for those terrifying situations where you have an uncontrolled zone 1 supramesocholic hemorrhage. The aorta is bleeding high up near the diaphragm, and you cannot get control of it distally or even easily see it.
So how does the Mattox differ from a standard left colon mobilization? How is it more aggressive?
The Mattox is a systematic, rapid, and aggressive extension of that left visceral rotation. The incision along the white line of Tolt isn't stopped. It's carried forcefully all the way up and around the spleen, dividing its lateral attachments, like the splenorenal ligament, and continues right up to the esophageal hiatus in the diaphragm.
So you're lifting the spleen, too.
You're lifting the entire left-sided complex, the descending colon, the spleen, the tail and body of the pancreas, which is attached to the spleen, and often the left kidney itself, all reflected medially towards the patient's right across the midline.
That sounds like a truly massive, almost violent reflection of multiple organs. What critical area does that expose, and how quickly does it need to be done?
It exposes the least accessible, most critical area in emergent aortic bleeding, the midline superior mesocolic region. It gives you direct sight and, crucially, access to the suprarenal aorta right up to the diaphragm, the coeliac plexus nerves, the root of the superior mesenteric artery, and the left renal vessels.
And speed.
It must be executed extremely quickly, often in literally seconds, by an experienced trauma team, because it's often the last-ditch effort to get above a tear or injury in the high aorta to gain life-saving proximal control with a clamp or manual pressure. It's a maneuver born of desperation but grounded in anatomy. Yeah. And just briefly, we should mention access via the lesser sac for pathology in the supramesocolic retroperitoneum, like behind the stomach or pancreas.
Right. How is that achieved?
Usually one of two ways. Either by opening the avascular pars flaccida of the lesser omentum, which is the thin membrane running from the liver to the lesser curve of the stomach, or, more commonly, by dividing the gastrocolic ligament, which runs between the greater curvature of the stomach and the transverse colon, entering the lesser sac from below. This gives access to the posterior wall of the stomach and the underlying pancreas and aorta. #Take 7. Tips, hazards, and pitfalls in dissection. Okay, so knowing the planes of maneuvers is step 1. Step 2, and arguably just as important, is knowing how those beautiful planes can break down and what deadly mistakes happen when the surgeon deviates, intentionally or unintentionally, from the safe avascular path.
You mentioned a fundamental technical principle earlier that sounds simple but requires real finesse. Traction and countertraction.
Right. It sounds basic, but effective safe dissection relies entirely on maintaining the dissection plane within that loose areolar tissue. To do that, you must apply enough medial traction, pulling the organ, like the colon, towards the midline, to put the white line of Tolt and the RMP fascia under gentle tension.
Why is that tension so critical?
Because that tension is what allows the blunt dissection, the sweeping or pushing motion, to actually work. It naturally separates the loose tissue layers along the embryological plane. If you don't use enough traction, the tissues remain floppy, the plane isn't obvious, and you risk inadvertently cutting into denser, more fibrous tissue, which increases the chance of straying too deep, too posteriorly, and hitting the ureter, gonadal vessels, or even the kidney itself.
But the single greatest hazard, the thing that throws all the rules out the window, is pathological distortion, isn't it? When disease messes up the normal anatomy.
Absolutely. This is where textbook diagrams fail you completely. Acute and chronic inflammation, think of severe smoldering chronic diverticulitis, or the fibrosis from chronic pancreatitis, or invasion from large tumors, or even just an old organized hematoma. These processes obliterate those beautiful, safe avascular planes.
How? What happens to the tissue?
The loose, easily dissectable areolar tissue is replaced by dense, scar-like, woody fibrosis. Structures that are normally separate become fused together in an inflammatory mass.
Can you give us a vivid example? Something surgeons dread.
A classic nightmare scenario is operating for complex, chronic sigmoid diverticulitis, down on the left side. The intense, long-standing inflammation causes the surrounding fat, the peritoneum, the bowel wall itself, and nearby structures to become incredibly dense and fibrotic, like concrete sometimes. The left ureter, which normally lies safely behind the RMP, can become virtually glued, incorporated into the wall of the diseased sigmoid colon by this scar tissue.
So the normal plane is gone?
The retromesenteric plane simply ceases to exist in that localized area. It's obliterated. If the surgeon attempts the usual blunt dissection, pushing medially thinking they're in the safe plane, they risk immediately tearing or even completely transecting the ureter because it's now inseparable from the structure they are trying to mobilize. Identifying the ureter before dividing anything becomes paramount and extremely difficult. Another significant hazard comes from the technique itself, overly aggressive traction, applying too much force, yanking too hard.
Especially in minimally invasive surgery.
Exactly. Especially in the magnified view of laparoscopic or robotic surgery, where the surgeon lacks that direct, tactile, haptic feedback. You can't feel the tissues stretching to their limit. This risks tearing fragile tissues, or, worse, avulsing major blood vessels right off their origin.
What are the classic high-risk avulsion injuries associated with the major rotation maneuvers?
Okay, during the right rotation, the Kocher extended into the Cattell Braasch, the absolute classic high-risk mistake is applying too much medial traction on the mobilized right colon and small bowel mesentery. This can avulse or tear the right colic, or, even more critically, the middle colic vessels right off the side of the superior mesenteric artery or vein.
And the consequence?
Massive, immediate mesenteric hemorrhage deep in the center of the abdomen and potentially catastrophic ischemia or loss of blood supply to the entire right or transverse colon, requiring a much larger resection than planned. It's a surgical emergency. On the left side, during a full Mattox maneuver when you're aggressively mobilizing the spleen, pancreas, and kidney medially.
What are the big risks there?
The major risks include tearing the spleen capsule, which bleeds profusely, directly injuring the tail of the pancreas. Or, a particularly nasty one, tearing the left descending lumbar veins as they drain into the left renal vein, or IVC, especially as you lift the kidney forward.
Tell me more about those lumbar veins. That sounds like maybe a minor bleed.
Oh, far from it. The descending lumbar veins can be surprisingly short and wide vessels, draining the posterior body wall directly into the high-flow renal vein, or sometimes the IVC itself. If they are avulsed from the wall of the great vessel during the Mattox maneuver, the resultant hemorrhage is rapid, massive, venous, so harder to stop with simple pressure, and deeply situated right against the spine. Controlling that kind of bleed, often through the already dramatic exposure of the Mattox, is extremely difficult and absolutely life-threatening.
Okay, scary stuff. Let's quickly summarize the specific structures most at risk during these major dissections, just to reinforce.
Sure, during right medial visceral rotation, Kocher, Cattell, Braasch, you absolutely have to positively identify and protect the right ureter, the right canal vessels, the duodenum itself, risk of perforation, the underlying iliac vessels, and avoid avulsing those middle colic vessels. Also, watch out for the gallbladder and liver capsule.
And for left medial visceral rotation, standard or Mattox?
Key structures at risk are the left ureter, the left gonadal vessels, the duodenum, again, as you approach the midline, the iliac vessels lower down, the delicate hypogastric nerves deep in the pelvis, which control bladder and sexual function, and of course the spleen and pancreas during a Mattox.
And finally, if you are dissecting via the lesser sac, entering behind the stomach,
Remember the posterior relationships. Structures immediately at risk include the transverse colon below, the greater curvature of the stomach itself, the epigastric vessels, the portal structures, portal vein, hepatic artery, bile duct, running behind the duodenum, the inferior vena cava, and the aorta and esophagus lying just posterior to the pancreas and stomach. Careful dissection is key. Hashtag tag 8, application and synthesis, clinical cases.
all right, let's try and solidify all this high-level knowledge by applying it directly to some clinical scenarios or questions. We need to know not just the names, but the operational context, right?
Application is key.
Okay, first let's reinforce basic location. The pancreas. Where does it primarily reside in that compartmental model?
The pancreas is located mainly in the anterior perirenal space, or APS, along with the duodenum and parts of the colon. This is crucial for understanding how pancreatitis spreads. Those enzymes are released into the APS and tend to track along the mesentery within that space.
Got it. APS for the pancreas. Next, let's revisit that complex case we touched on. Accessing the left adrenal gland, maybe for an adrenalectomy for Cushing's syndrome. Where is the adrenal gland itself located?
The adrenal gland, like the kidney it sits on, is in the perirenal space, PRS, that central compartment defined by Gerota's fascia.
So to get to that primary retroperitoneal structure on the left, what layers or structures must the surgeon typically mobilize or incise first?
Okay, to reach the left adrenal, which sits high up and posteriorly, the surgeon usually must first detach the lateral attachments of the spleen, specifically mobilizing along the avascular splenorenal ligament, and gently reflect the spleen and the attached distal pancreas medially. That exposes the anterior surface of Gerota's fascia covering the kidney and adrenal.
Is that always enough exposure?
Often not, especially for larger tumors. To get better, wider access, they frequently also need to take down the splenocolic ligament connecting the spleen to the colon, and then incise the white line of Tolt along the descending colon. This allows further division of the retroperitoneal attachments of the pancreas tail and splenic flexure, dissecting in the avascular retromesenteric plane, RMP. All these steps might be necessary just to get adequate, safe exposure of that left adrenal gland nestled deep in the PRS.
Wow, okay. Multiple steps involving multiple planes. Now back to trauma. Patient comes in crashing, hypotensive, open abdomen, shows a massive, rapidly expanding central hematoma that's clearly above the transverse colon. You need immediate proximal aortic control. What is the fastest standard surgical maneuver to get access to those superior mesocolic great vessels?
That is the absolute textbook indication for performing a left medial visceral rotation, specifically using the full Mattox maneuver. It is the designated trauma maneuver for rapidly exposing and controlling bleeding from the suprarenal aorta and its major branches.
Mattox for high zone 1 bleeds. Got it. Now for more routine general surgery. Let's say you are performing a standard right hemicolectomy for colon cancer. The crucial step of mobilizing the right colon medially is performed by dissecting safely within which specific avascular plane.
That dissection occurs within the retromesenteric plane, or RMP. That's the embryologically defined safe highway. Dissecting here ensures the integrity of the colon's blood supply, which stays attached to the colon as you lift it, and it protects the underlying primary retroperitoneal structures, like the right kidney, ureter, duodenum, and gonadal vessels, which remain safely behind that plane.
RMP for colon mobilization.
Perfect. And finally, let's reinforce incision choice again. Imagine a patient has a very large, aggressive right adrenal tumor. It looks like it might be invading the vena cava, maybe even extending up towards the diaphragm. What surgical incision provides the absolute best exposure for attempting a curative en bloc resection, ensuring clear margins and vascular control? For that kind of extensive, challenging pathology involving the upper right retroperitoneum with potential thoracic extension or major vascular involvement, the incision providing the maximal possible exposure and control is almost certainly the thoracoabdominal incision.
The big one.
The big one. It allows the surgeon to simultaneously address potential invasion into the diaphragm or even the pleural space in the chest, while maintaining full control over the IVC and the entire retroperitoneal field from both above and below. It maximizes the chances of a complete margin-negative resection in very complex cases. #tag outro.
So we've really taken a journey through this incredibly complex architecture, the posterior abdominal wall and retroperitoneum. We've broken it down from its microscopic embryological beginnings, through its fascial compartments, right up to its role in high-stakes trauma surgery and complex cancer resections.
Yeah, it feels like we've peeled back the layers literally and figuratively. And I think the central lesson, the key takeaway, has to be understanding just how critical adherence to those embryologically defined avascular planes really is. Surgical success and patient safety in this region hinge on respecting those lines of fusion.
So what does this all mean for you, the high-level learner listening in? I think it means that true surgical mastery, particularly in this unforgiving anatomical region, is about recognizing patterns laid down millions of years ago in our development. There really shouldn't be guesswork, just the systematic, leveraged use of these planes.
Well said.
Recognizing the subtle tissue differences that signal you're in the retromesenteric plane, knowing precisely when and how to execute a massive, potentially life-saving maneuver like the Mattox maneuver, that's the kind of knowledge that elevates your understanding far beyond the basic anatomical facts.
Indeed. And, thinking about the future, given those inherent risks we discussed, especially the hazards of overly aggressive traction and the potential for devastating avulsion injuries, which might even be magnified in the era of limited haptic feedback from robotic and laparoscopic platforms. It raises a crucial question for surgical innovation, doesn't it?
What's that?
How might emerging technologies like augmented reality overlays in the surgeon's view, or perhaps advanced intraoperative imaging, how might they better highlight those precise loose avascular planes, the white line of Tolt, the filmy layer over Gerota's fascia, the RMP itself in real time during surgery?
So technology could potentially provide that missing tactile information visually.
Exactly. Could it help prevent surgeons from inadvertently straying off the safe path into dense, vessel-rich, adherent tissue, especially when pathology has distorted the normal anatomy? Could it make these complex dissections safer?
That is the future of safety in the retroperitoneum. A really great thought to end on. Thank you for joining us for this deep dive into surgical anatomy. We'll see you next time on The Deep Dive.